Welcome everybody to this DementiaSA webinar series. This is our fourth webinar in the month of September in honor of World Alzheimer's Awareness Month. So we're very happy to have you all here. I'm especially happy to welcome Dr. Julie Ettelin to this forum today. I know Julie personally and am a huge fan of hers. But more formally, so Julie is a family GP who worked on the Atlantic Seaboard since 2001. She sees patients across all ages and particularly enjoys the aging population. What she loves about being a GP is the privilege of sharing many experiences over the years with patients and their families. Julie always knew she wanted to be a GP. Her father's a GP in Neisner, and he inspired her to follow in his footsteps. After graduating from UCT, she traveled to the UK and completed various 6-month posts in psychiatry, pediatrics, emergency, and general medicine. She decided to return to South Africa to start her career in general practice. She's always felt passionate about having a holistic approach to patients and illness management. This led her to complete 2 modules in integrative medicine through the University of Stellenbosch. She has since been studying further in the field of functional medicine, which focuses on investigating the root cause of health problems, thus allowing her to manage each patient as an individual with a unique set of circumstances. Julie also offers DNA testing with a focus on weight management, health risks, females' estrogen metabolism, and sports performance. She's completed a course in translational genomics, enabling her to understand how genes impact on the manner in which you respond to the world around you. Further interest in identifying risk factors in relation to Alzheimer's disease and preventing cognitive decline. Julie's a registered RECODE practitioner, having completed Dr. Dale Bresden's course. She's very excited about this direction it's taking and the possibilities for a novel approach to healthcare, specifically cognitive decline. So with that, I'm going to hand over to Julie. Julie, we're so glad to have you here. Thank you so much. I'll hand over to you.
Thanks very much, and thanks Abigail and DementiaSA for inviting me to partake in this discussion in the month that we sort of focus specifically on Alzheimer's and dementia. And just so Abigail's given you the background, and I've been in private practice now for 20 years on the Atlantic Seaboard, and the Atlantic Seaboard, there are quite a lot of old age homes, and the practice I joined actually had quite a lot of elderly patients in it, and I discovered that I really enjoy working with the elderly. So I've got a large elderly population. And I think until I did my studies into genetics and realized with the gaining knowledge about a specific gene, the ApoE4 gene, and one's genetic risk for Alzheimer's, I hadn't really given it too much thought. I sort of thought dementia, we might diagnose it. I have the one memory test to check for it, and then I'll get a specialist opinion. And what I noticed is that over the years, but I didn't have the tools to address it in a more holistic way. So I now feel so learning about the ApoE4 gene, I then read about Dr. Dale Bredesen and his research into Alzheimer's and cognitive decline and how he approaches it. And the way he approaches it really resonated with me, as it looks at really at Alzheimer's as another chronic illness, and that we need to manage it as such, but that it's a disease of lifestyle. So we need to start making the changes much, sort of 20 years before the development of this of dementia or this illness. And so it got me very enthusiastic about the potential that I have as a GP. I don't need to be a specialist to be making a difference in people's lives. So this led me to firstly reading his book, which I don't know if any of you have come across it, The End of Alzheimer's. I'm going to hold it up here, and if you can all see. And so I read his book, and there's a lot of scientific information at the beginning, which I know I've recommended for a couple of patients, and that's been a bit heavy. But that for me was a real game changer, and in terms of my approach and my thought processes around how we should be addressing patients who are developing cognitive decline and Alzheimer's. And he's just actually released another book now called The End of Alzheimer's Program, which is a much more hands-on program, a book with diet and all the blood tests, and it's a lot more sort of patient or family friendly, so that one could get going on that program, you know, on your own at home. So that's led me into just really looking at dementia, cognitive decline in a more holistic fashion, and I'm really enjoying digging deeper into sort of why somebody might be having memory issues, because it doesn't only happen to people when they're much older. It can start some people start in their 50s, some people start in their 60s. And so for me, it was really about having the tools that when somebody came into my rooms, that I felt that I could address their issue of their concerns for memory difficulties with a much more holistic approach, and actually take it seriously from the get-go. You know, often we'd say, oh, that just sounds like, you know, age-related change, or yes, it's let's see how we go, and let's see in 6 months, or let's see in a year. But that is a bit crazy, because we are then missing out on valuable time that we can be looking for any possible reasons why this might be happening, and instituting the changes, which, as I've said, a lot of the physiological processes which then lead to the cognitive decline actually start 20 years before. So we really should be looking at this all in our sort of mid-40s, or and Dr. Bredesen talks about something called a cognoscopy. We all know about colonoscopies that we have done when we are 50 or above, looking for colon cancer. But this is the cognoscopy is really looking at your cognitive function, and looking at areas where we might need to pay some attention. One of those areas is around the genetic risk, and that is the ApoE4 gene. And that is a gene that we can test for. And originally, people were saying, well, why would I want to know that? That's so scary, and I wouldn't want to know that. That's going to sort of totally freak me out, and there's nothing we can do for it. And that's the main sort of thought processes around it, is that, well, there's nothing we can do, so we'd rather not know, and let's hope that nothing happens. Whereas actually there's a lot we can do, and it's lifestyle, and it's simple things. It's diet. It's looking at what we are eating, looking at what we try and avoid eating, looking at various supplements we might be taking. It's looking at exercise, looking at not only the physical exercise, which is critical, but also your mental exercise. And it's no wonder that we find when people retire, and if they don't have lots of interests and things to keep themselves busy, that's often when we see that cognitive decline setting in, or it becomes more noticeable. So exercising the mind is critical, and I see that with a lot of my elderly, that, you know, they might read a bit, or they're doing the odd crossword, or what they used to do, but not enough. And it's every day. One needs to be doing a little bit of something every day, and it's simple things like puzzle building, keeping your playing a game, playing memory games. You can do the Sudoku, you can do the crossword, or it's a simple thing like, if you're right-handed, practicing writing with your left hand, because we just trying to form new neural networks, and trying to keep that brain functioning at its optimum. So that's the exercise, which is critical. Obviously also the physical exercise, because moving is going to improve just blood circulation around the body, and oxygen flow, blood and oxygen flow to the brain, which is critical. So that's critical. Another thing which is simple to address is your sleep. sleep is critical to our mental function and to our brains. I mean, at night when we sleep, and we need at least 7 hours, not more than 8 hours, so 7 to 8 hours. And that's the time when our brain lymphatics work, and that's the time when we have to detox. And so our systems really need that sleep so that our brain lymphatics can work. You know, it's the only time that they do work. So we need that time to give just our systems a break, and also for our lymphatics to be able to clear anything from the brain at night. And then stress. I mean, stress is a massive factor. So in terms of looking for ways to manage stress, so it could be breathing techniques, could be yoga, could be just walking in the mountain, or somewhere that is calming for you, and that does help stress relieve. Or it could be just meeting with friends, or sharing your stories with other people. That's also a form of stress release. And so it's really about looking at those critical factors. And I find that these days a lot of people eat a lot of fast foods or pre-prepared foods. There's a lot of salt in those. With the fast foods, there's just a lot of sort of saturated fats, and we're not feeding our brains, and we're not feeding our bodies as we should be. And so I often try and think about it as when you're cooking, or when you're deciding what you're going to eat, you sort of look at the food and think about, is this really going to be helping my brain or hindering my brain? And trying to make healthy decisions along the way. You know, there's so many things we can do, but it's also just important about making that start and deciding that, okay, I'm going to just address this aspect. You don't have to do it all at once. I found doing this program, and so because I was so interested in it, I registered and did the program through the States, the Dale Bredesen Recode protocol. So I am a Recode practitioner, registered practitioner. And so there's lots of changes to be made, lots of bloods to be done, supplements to take. And it can feel quite overwhelming, but actually it's often simple things. I've got patients who don't go on the full program, and I've got patients who just have focused really because for them it's more their diet, and they were eating far too many sugary foods or drinking too much alcohol. It always amuses me. I have one gentleman I'm very fond of, and he came in and he'd heard about me through his daughter, and I said, how much alcohol do you drink? And he said, oh, not very much at all. So I said, oh, okay, great. How much? And he said, no, 24 beers a week. And my face, I kind of went, I really was, and we laughed together because he was shocked that I was shocked, and I was shocked that he wasn't shocked. So, and since then, we've worked together with mainly diet, not that many supplements, and he's done remarkably well in terms of the scoring on his, I use the MOCA, the Montreal Cognitive Assessment. I know people use the mini mental state exam as an assessment, but on that he started off at 23 out of 30, and now he's scoring 28 out of 30. Very interesting, and he's quite skeptical, and at the beginning of the program told me he really wasn't doing that program. He was sure it was a whole lot of nonsense. And so I took parts of it and just adapted for what he could do. And even when I saw him 2 weeks ago, and he kept saying, you know, I don't know, I think I know I am better, but where's the evidence, Julie? Where's the evidence? And I showed him his Montreal Cognitive Assessment from our first session, and I showed him his most current one. And just from drawing the clock face and copying the cube, and just the precision and the improvement. I mean, he was he couldn't believe what he'd done on the first session. So it's lovely to have some evidence like that of the improvements. And then I've had other patients who can't, you know, who've been further down the line, because he was 23 out of 30. So it wasn't too bad. I've had some patients who scored 3 out of 30. And then they scored 7. And what we realized with the family, we weren't so worrying about the score. It was what they were able to do, and how their family perceived them, how the carers were perceiving them, and the level of independence that they're managing to attain. And I've got one lady who was 3 out of 30, who's now able to drive her golf cart when she come, and she has a carer a day and not at night anymore. But she can visit her daughter's house. She doesn't get confused anymore. So it's those changes. It's actually so whether she scores, what her score is on the assessment. It's not all about the score either. It's just about the whole family, that everybody, the relationship between mom and daughter is so much better, and it's about the quality that of life that you can still have with your loved one. And I think, and so that for me has been very interesting, that it's mustn't focus so much on the score at the end of the day, although it's nice to see, and obviously for me, I like to track that, and that's important for me to see the improvement. But actually for the family, it's about the experience. And so I found that incredibly rewarding. Because I still run a full general practice, I haven't put it out there that this is what I'm doing as much as I maybe should or can. And so I'm really looking to moving much more into making this a bigger part of my practice. So, and very excited about the possibilities, and the possibilities that that people can really take on at as little cost as they can afford, or as much as they can afford. And I think at the end of the day, if we look at lifestyle, that's critical. We really got to be looking at our lifestyles as to how we're going to be later on. I mean, it's the same thing with cardiovascular disease or diabetes, and those are all risk factors in terms of your chances of developing dementia, Alzheimer's at a later age. So we've really got to manage those at younger ages. And so I also see a lot of kids of patients with Alzheimer's or dementia, because they're wanting to really look at their risks and look at what can they do now early on, so that they don't follow that same route. What else? I think, Abigail, I'm not sure. I think I've sort of spoken quite a lot now, and I don't know if there are any questions from anyone.
Thank you so much, Julie. So I have 2 questions that came in via our support group. So I think let me kind of read those 2, and we can start with those. And I think if anyone has other questions, so this is a question that came in. It's a small drug question. With, oh my God, excuse my pronunciation, donazepam. Does size of dose affect effectiveness? Apparently, even very small doses can be effective for Lewy body dementia. Same for risperidone. Is a smaller dose effective as they are so sensitive to this? Did that question make sense? I mean,
so look, so the donepezil, I mean, look, different people are sensitive to drugs, and different people, it's like antidepressants, or people react differently. Some people can have a smidgen of a dose and it makes the difference. So I think as long as the benefits outweigh any side effects that you're having, I think it's always good to try and go on to the full dose, for example, of the donepezil. And we can just see if I'm answering your question. But a smaller dose, I mean, the studies have been done on the full dose. So I think, that is the dose that we would be going for. But if you are having good results on the smaller dose, I don't see why not. But the studies have been done on the full dose. In terms of risperidone, I know, the dose, it 0.5 milligrams, which is the smallest dose, can be effective. But some people then go on to need higher doses. So it really is about monitoring your family member's response and then adjusting the dose accordingly.
Okay, great. Thank you. Okay, and another question. Okay, so it's two questions. The person says, my mom has trouble swallowing her tablets with liquid and often coughs or chokes with water going down the wrong way. I'm concerned about her getting ill with aspiration pneumonia. Her chest is very wheezy. Any tips or aids for swallowing difficulties?
I think you could use like simple thickeners. I mean, there is one we use as an infant formula called Nutilis, Nutilis, because we often use that in little ones to help them so that they don't, or even, but just maize, thickeners, just cooking thickeners, those can help. So, and you could just mix that up. If it's with your pills that you're mixing with a little bit of water, put even a bit of thickened, even a bit of potato or like mashed potato or something like that, or maize, and that can thicken it enough to help with the swallowing. Or you do get proper sort of, as I say, the Nutilis, which is a proper thickener.
Okay, great. And the second question is, so from the same person, this person's mother has memory gaps where she confuses me. So I'll read it as it's come through. So it says, secondly, she has memory gaps where she confuses me, the primary caregiver, with someone she calls her other Lynn. There is no other female in the home, but insists it was the other Lynn she spoke to about this or that. Or she'll ask to phone her real daughter, Lynn, me, or she will suddenly ask where I have been for the last few days. I understand this is part of her memory loss, but distracting her is difficult as she sees me nearly 24/7. Any tips on how best to manage this? I find it difficult not to correct her, but doing so is causing her anxiety and more confusion. She's quite wily.
And that is, I mean, it's so tricky. And I think for the person to be having that same either question or the confusion. And I think the best, if she says, well, where is Lynn? Say, well, when did you last see her? Just so don't try not to try and just talk through it, posing a different question to her. When did you last see her? Or, oh, what did she say when you spoke to her? Or, and often that can just distract onto and keep a little bit of a conversation going, but you're not sort of making her feel uncomfortable because she's got it wrong again. So I think if you can use those kinds of tools.
Okay, terrific. And I've just got a question sent in asking at what point, it says, at what point in the journey do we, when is it appropriate and not appropriate to call one's GP with various kind of symptoms of how, is that a personal relationship? If you could maybe,
I think it's always appropriate to call. I mean, I think if you're having difficulties, I think call your GP, because that's what your GP is there for. And I think if you've got a good relationship with your GP, they will always be happy to try and help you and to steer you in the right direction, should they not be able to help you. So, and I guess it depends on, I don't know if person wants to elaborate on particularly what questions. Is it about, which aspect it's about? But I think, and that's where I really value my role as the GP, because I feel that I can really be that sort of glue for between the family, the patient, the specialists, and I can be the person that can find out or speak to the specialist or just be an ear to listen to what's happening and point them in the right direction. Because they might it might be something quite simple, or maybe you just need to run it by someone so that you've run it by someone and that it's okay what you're doing and you can carry on. So I think to find, your relationship with the GP is very important, and that's where I feel very honored to be that role often in a family's life, of the go-to person and being there and just really trying to help them manage a really very distressing situation. And I think as long as as long as I can be that for the family, I think I'm doing, I'm of value and doing a good job.
Terrific, and I'm sure you are, and I know you are. Guys, I'm going to open the floor up. Does anybody, I think, maybe use your raise hand function or unmute yourself if you'd like to ask a question, or maybe put it into the chat function. I know we get some questions on Facebook, but I'd love to allow everybody here the platform to ask.
There's something else while we're waiting for some questions.
Okay.
I think the other thing I just wanted to say is, it's very important. I feel for me now as a GP that I have this. There's a skill now with addressing cognitive decline, and especially in patients who are coming in earlier, or even in the elderly. I think at medical school, we're just not trained very well, unfortunately, to manage it well, or to manage the assessment. And so I'm quite excited now when people come in. Well, I'm not excited for them, but when they actually bring it up, and I feel like I have something of, that I can offer, and a framework to work within that can really be of value. So I think, they're the basic blood tests we do. There's a couple of basic things we always do. Your vitamin B12. I'll talk a little bit around, what I might do while we're waiting for questions.
So, Julie, can I pause you for a sec, because I see Chris
Sure.
has unmuted herself, and so has Vivian. Chris, did you want to ask a question?
I've got two questions.
Okay, perfect. And Vivian will come to you after Chris, if that's okay. Great.
Okay, my husband suddenly decided he doesn't want the carers to help him to bath or go to the toilet. He wants me in the room all the time. And if I do go out too, he won't eat or drink until I come back. He'll just wait for me. So it's now becoming a slight problem, in that he's becoming very difficult in that. And we don't quite know what to do. I mean, you can't have a discussion with them. There's no reason anymore.
And I think, and that is very difficult, because there's the loss of reasoning, and you can discuss it to death, literally, and still be in the same situation. So, I mean, my advice in that situation would be really, I think, for you and for the preserve of your mental health and your ability to go out and have your time on your own. You need to, he's not going to starve if he doesn't eat the meal if you've gone for a couple of hours. If he decides not to eat while you're not there, then so be it. I think what's important is for you to have that space and do what you need to do as well for your mental health and for your sort of, so, and so, yeah, I think that's what I would suggest.
Okay. The other question is, with Parkinson's, when do you know it's time to stop driving?
Well, I mean, I guess it depends on his.
No, he's not driving it. This is me now.
Oh, I see. Oh, you've got the Parkinson's.
Yeah.
Well, I mean, it would really depend on your, how you felt in terms of because obviously mentally you're 100% able to know. It's just the shake that's causing an issue.
Yeah.
And I think, I mean, I would probably say sooner rather than later, so before it becomes an issue. I mean, it's difficult to know without, sort of assessing your level of tremor and that. So I think that would be needed. You would need to sort of have a review with your GP about that. I mean, it's a bit tricky, but yeah.
Okay. Thank you.
Thank you.
Thanks.
Lovely to have you
Abigail.
here. Okay, we had. Sorry, I've suddenly gone blank.
Vivian.
Vivian, sorry. Vivian, do you want to unmute yourself?
Unmute. Can you hear me?
Yeah, we can.
Yes, we can.
Okay, great. I'd like to think that I'm in the beginning stages of my husband developing dementia. But unfortunately, I've had my head in the sand. So if I could just give you a bit of background, he's 72, so he's quite a bit older than I am. And about a year ago, he's got utmost trust in his GP, who we went to go and see, and he did a test 1 out of 10. I don't know if you know those tests, Julie. I think it's a straightforward one, like you saw an orange and then you saw an apple. Yeah.
Mm.
So Shane scored very highly on this thing, and he was quite happy about it. The doctor then called me to the side and he said to me, "It's an ongoing process, so watch it." Anyway, and I'd honestly say, when I speak to his family, especially my stepdaughter, she has noticed it for 4 or 5 years. I've tried to not hide it, but try and in denial. Okay, so it has got worse. He has got diabetes, and he's got essential thrombocytosis, which is like a blood disorder. So we see a doctor for that. So we went to the doctor yesterday. His bloods were good. I emailed the doctor before and I said, I have this problem. All his friends have noticed it. He's golfing, but he's still very physically fit. He plays golf 4 times a week. He's still driving. I'm concerned about his driving. He eats well. He sleeps well. He has started with anxiety. And as this hematologist told him yesterday, the more he the more he forgets, the more anxiety he's going to expose himself to. So he firmly suggests that I've had him booked into a Dr. Van Heerden at Vincent Pallotti for the test, 11 January this year. The day before, he refused to go. So I just honored his, respected his decision, and I've left it. So now the hematologist has suggested that he does do this. I have a daughter who's an occupational therapist. Thank God she's moved down, and she is supporting me very much in trying to get him to go for this test. I can't, I can give you examples of behavior. He has got some aggressive behavior at times, like masks. He'll accuse me of hiding his masks. He forgets to take his meds. A very important fact is that he was a top businessman. So his broker, his investment broker, and his lawyer have been in touch with me and said to me that I need to address this urgently. So that's why I'm here. I'm also, if I can just say that I'm feeling terribly guilty. I'm feeling terribly guilty because obviously I'm doing all this behind his back. I'm speaking to his lawyer. I'm speaking to his investment broker. I've emailed my close friends. I've emailed his friends. They've all noticed it on the golf course. And, people tend to sort of hide or push it to the side when this does start happening. He's got a business partner who was rude to him because he keeps on repeating himself. So it's a hurtful position I'm in at the moment. And also he's in denial, but he also admits to me that there is a problem. My big question is, how do I get him to an assessment? Sorry for the long story.
Sure, Vivian. Yeah. I think, what about your GP? I mean, I'm assuming he's got trust in your GP.
Yeah, a lot of trust. We've been to the GP.
Yeah.
We can go back.
So what I would maybe suggest is, and especially if he's identified that, himself, that he's a bit worried, there's something, that perhaps you also just phone the GP and just say, look, we need to, I need you to tell him that we need to go to Dr. Van Heerden. And maybe, and that, because he might listen to the GP over you. I don't know who suggested it last time.
I'm sure anybody who's listening now will, the wife does everything wrong. The wife does everything wrong. You'll listen to Jenna before me. So Jenna's an occupational therapist. She has undertaken to get him to Dr. Van Heerden, which I am so grateful for. So I've placed my confidence in Jenna, and I don't necessarily feel I need to go back to Dr. Verman, I need to maybe follow Kotze now. He's hematologist.
Definitely.
So is that good enough that Jenna was with us in the meeting with the hematologist, that the hematologist has suggested to make the appointment?
100%.
Is it? Okay.
Yeah, 100%. And what I would suggest is just make the appointment. That's the first thing, and then go about how you know, let's get the appointment. But I think, and then Dr. Kotze can always phone, or Jenna or whoever can tell him that we just want an assessment, and just reassure him as he's noticed there's something, you know, you just want to investigate and do whatever needs to be done. And I don't know if anyone else, Abigail, I don't know if anyone else has got advice for Vivian that's been in the same situation. I'm sure there are many people.
Can I ask you one thing? The feeling of I'm imagining things, is that a normal feeling?
You mean for you?
For me. It's been pointed out to me by his best friends, his golfing friends, and that kind of thing. His daughter keeps on telling me, "Mommy, you're not imagining things." I know this is not about me, but I'm thinking, how can this man still play golf and drive to the golf course and remember the way? Whereas he won't remember his keys, he won't remember where his masks are. He'll someone will pay him his golfing money, and he'll say, no, you haven't paid me. So I need reassurance that I'm not imagining things, and that is obviously just to get this test done.
Of course, not at all. I mean, obviously his long-term memory, so his driving to the golf course and his drive, you know, that's not new stuff, but obviously putting his keys down or remembering where he put his mask, that's all new information that he's not able to retain. But also, you know, I think it's always like that when we notice something, you know, we try and that is there, but that's potentially disturbing or distressing for the person or for yourself. You know, we do second guess ourselves as to whether this is, you know, are we imagining it? Is it as bad as we think it is? And I think the fact that you know, everybody else is telling you as well, his business partner, his lawyer, his everybody. So everybody's noticing it.
Okay, cool. Thank you. Thanks for that.
Vivian?
Yes.
So I'm not sure, you said that you got the login details for this call via somebody who knows Julie, but DementiaSA have a virtual support group that we run every Thursday. We also have a WhatsApp support group. So if you'd like to join it, you can put your details in the chat function. You can put them just to me and I can add you to the WhatsApp group. And we meet once a week virtually as a support group, because one of DementiaSA's core functions are our support groups. And obviously with the pandemic, we've had to go virtual. And it's a lovely group of people. Most of them are on this call now. So if you want to just put your details in the chat function and I can add you.
Are you still Zoom calling? So it's still a Zoom call meeting.
We found a lot of people that also, to get away for the time to go to a physical support group, people were finding that demanding. So we will continue to do the virtual support.
Okay.
It is now a core competency of ours, so we'll continue to do that.
Okay, cool. Okay, no, that's fine. I'll let you know my details.
Okay, terrific. Thank you so much.
You can add me to that group. If you can add me to that group.
Perfect.
Add me to that group. Yeah. Okay, thanks.
Getting to know you. Okay.
Enough from me.
Dr. Ettelin, so I have another question here. So the test that you're referring to, is that something that people can do at home with their loved one? And if yes, where could they get that from?
The memory test I'm talking about, I'm assuming, the MOCA. So you need to be you need to know how to do it and what you allow the person to do. But there is a little, I'm sure, what have you got on DementiaSA, Abigail? I'm not sure. Like a little questionnaire. I know there is one that is on the Recode, that's just a little questions and answers that I could send to you, I could make available to you, unless DementiaSA has got something about whether,
Claudine,
I'm sure they have.
That was you who asked that question. Claudine, so as you know, I mean, we have two social workers. I think they're both on this call, actually, on this Zoom platform. if you'd like one of them to contact you to discuss that. I actually see that one of the social workers, Leonie, is that you that has unmuted yourself?
That's me. Yeah, Abigail, yes.
Hi. So
we do not ask, sorry.
No, carry on.
Okay, the DementiaSA social workers do not ourselves apply tests like that. And the reason being that when a person has symptoms that look like dementia, we want a proper physical assessment by an interested doctor, because there are so many physical possible causes for symptoms that can be dementia. So we want people to start with a good physical assessment. And then obviously when a doctor did not find any physical causes for symptoms that look like dementia, then one moves on to the MOCA or whatever other cognitive testing one feels would be appropriate in the situation. But the DSA social workers do not do those tests with people. We want them to get to the doctor first.
Great. Thank you. Thank you, Leo.
Yeah, I mean, yeah, and a good point. I only do those MOCAs on patients that have come to me with that are worried about their memory. So, but then I've done obviously the physical stuff. So yeah.
So I've got two questions that have come in off our social media platforms. So the one is, describe how a GP can fit into the care team. Kind of once somebody has had a diagnosis, how does the GP fit in to the care team?
So I think the most important thing, and I think as a GP, is always first, because sometimes people get to the specialist or they get to wherever they go and have assessments, and we don't always know that they've been. So the first thing is obviously just let your GP know that you've had that, been through that process, and that this is now the diagnosis. And so as the GP, I would love to know, who's in the care team, so that we know, and who are the primary people to contact. I like to have a list of that on my patient file, so that if anything happens, that I know who the people involved, and I've got their numbers. I think then, as earlier, as a support to the family. So I think that's a big role. And then also making sure, because now, people have got a cardiologist, and they've got a neurologist, and they've got a gastroenterologist. So I've got all these people, and everyone's doing their little speciality, but you need somebody who's looking at the whole picture. So I feel my role as the GP, or the GP's role, is also to hold all of that information and to flag things that might not be done because, one specialist thinks the other one's done it, or I often say to the patient, okay, well, when last did you have bloods? And, oh, they did full bloods, whoever it was. And then I actually have a look, and it wasn't full bloods. It was just, whatever's pertaining to their speciality. So it's just making sure that all of those things are followed up properly. But I think the GP is plays a critical role in that care team, and should be part of the care team, definitely.
Great, thank you. Okay, I've got a question here on the chat. It says, my mom won't wear her, excuse me, let me start that again. My mom won't wear her hearing aids, and she's very deaf. I think this is making her more isolated and confused, but she refuses, saying that there is nothing wrong with her ears. She says her hearing has improved again. In the next breath, she will say that she can't hear. So no rationality. Is there a way to encourage her to wear her hearing aid more?
That's a tricky one. Don't know if anyone else has got some top tips. And I mean, I'm not sure. I mean, I think to try and encourage, to say, well, let's say, Mom, let's try this for 10 minutes and see. I'm going to put the TV on. Maybe you make it into a little bit of okay, so here's the TV, or here's the TV on. Now let's put your hearing aids in. Let's see if you can hear the TV now. Let's see if there's anything different. Is it too loud for you? Let's, and maybe use something like that as a tool to get them to give it a try, that you don't make it so much about, or you could say, I think the TV is a bit loud. Should we see, put your hearing aids in. Let's see if you can, if it's too loud for you as well. I don't know if anyone else has got some tips, but I'm not sure. How else?
Yeah, I think, does anyone else Well, I guess raise your hand if you do. I see, Leonie, I see that you've unmuted yourself. Did you have a tip for that?
Yeah, there's always the possibility that a person using hearing aids have too much background noise coming through. And if it's a person living with dementia, the noise can be very disturbing. So maybe that could also be a reason why the person is not wanting to use the hearing aids on an ongoing basis. Just a thought.
Great. Thanks, Leonie. Dr. Ettelin, you were talking before we started the questions about the vitamin B12, I think. You had wanted to, or vitamin B6, you'd wanted to say something.
The B12. I was talking about just generally doing blood tests and looking at, because if we look at, when we're looking at the types of Alzheimer's particularly, and looking at, I mean, according to Dr. Bredesen, he's typed them in terms of sort of 6 different types, and so that one can look at what the particular cause is. And so often, you know, type 1 is what we call type 1 is inflammatory. So that would be anything that causes inflammation in the body. So we'd be looking at things like infection, what kind of diet are you eating? A very inflammatory diet. Are you eating a lot of fast foods and a lot of fried foods and a lot of and not enough of the vegetables and the good, or too much sugary things, too many sweet things, and then just infections can cause inflammation. So then in terms of, we do specific bloods according to that. And where the B12 comes in is where we look at what we call trophic, or the lack of the right nutrients, which are important for your brain health. And B12 is one of them. Your thyroid hormones, your estrogen, the sex hormones are important. Iron is important. Zinc, magnesium, those are things. So we like to look at those because when we look at our brains and our brain function, we want to turn on the sort of neuron maintaining connections and keep those going. We don't want to turn on the connections that are, we don't want to turn on the pathways that are blocking those connections and actually breaking down our neurons. So things like vitamin B12, magnesium, those are all very critical in our brain function and sort of supporting ongoing good brain function.
Great.
So B12 is very critical, and I think we don't pay enough attention to those, or certainly, I mean, I speak a little bit differently, is that the ranges are also, you know, the acceptable range for vitamin B12, or adequate actually, is 220. So for me, I want that B12 right into the 500s at least. So for most practitioners, they might say, well, 220, you're fine, or 240, you're fine. But we don't know if that's fine, because we're all unique and individual. And the normal is above that. And what's your normal? Who knows what your normal is? You may have a much greater need for the, you know. So I like to check that, and then supplement accordingly, and also follow up and see, you know, what differences has it made. And what I think often is a great way to know is to do a course of a couple of vitamin B12 injections to see, because sometimes your level in the blood might look okay, but that's your level in the blood. It's not really the level that's sitting in your tissues. So we don't really know 100% what's happening. So I like doing a short course of a couple of B12 injections and seeing what that does, and seeing how that affects.
Great, thank you. So Karen has sent through, sorry, and I should have mentioned this, Karen is out on the road for Alzheimer's Awareness Month. DementiaSA are donating dementia packs to various underprivileged facilities. And it includes books from our library, and masks, and fidget blankets. And Karen, in true Karen style, has decided that she's hand delivering these, which is absolutely wonderful and lovely. And so she has sent a question through. And before I ask that question, because I think it may be our last one for the day, just a reminder to everybody, and those who haven't been with us, I'm going to post, we do a survey on these webinars, just to get an idea of kind of what people take away from them, but also because DementiaSA, as we change our focus slightly to being wanting more monitoring and evaluation in the organization, and kind of really being able to position ourselves where we can help people the most. So I'll post that to the chat, but I'm going to read Karen's question. She also says, thank you so much, Julie, and sends her love. She says, with your experience around kind of genetic testing, could you speak a little bit about dementia being genetic or not, and how those tests kind of, what people, in a practical way, what people, because most people on this call who aren't professional caregivers are loved ones and caregivers, and so that would impact them.
Thanks, Karen, and thanks very much to you and Abigail for having me here today. So the genetic testing, I mean, there's different genetic testing. There's the very early onset, and that's presenilin 1 and a couple of other gene tests that are very specific. And for those tests, and that would be for early onset dementia, sort of less than younger than kind of 50 and younger, and so that I would do through a genetic counselor, because when you have those genes, you're getting Alzheimer's. That's the path you're going. But the genes I'm talking about, the ApoE4, is a genetic test which you can have at PathCare. It is pricey, but you can have it at PathCare, and it's offered on the panel that we do. What that tells you, so you inherit your genes from mom and dad. You get one gene from mom and one gene from dad, and usually there's an alphabet that we get. So, but with the ApoE genes, you get either a 2 or a 3 or a 4. The ApoE4 is the one that we're concerned about with your risks for cardiovascular disease and dementia, and particularly Alzheimer's. So what we find is we'll inherit one from mom and one from dad. So if you have no ApoE4 genes, i.e. you've either inherited a 2 or a 3, or you 2-2 or 3-3, depending on what you got from mom and dad, so you've got the 2 genes, but there's no E4, you've still got a 9% chance of developing Alzheimer's. If you have one of the ApoE4 genes, you've got about a 30% chance. And if you've got 2, you've got a more than 50%. Some people even say up to 80 to 90%. So what we call the homozygote E4. What's important to know about the E4 gene is there's a lot of good research out there about specifically if you have that gene, specific diet that we need to look at, and really specific things that are very pertinent to ApoE4 carriers. So I think it's a very useful test in terms of looking at your risks, and as a family member, particularly if you have a parent with Alzheimer's. And I think the other thing, as I said earlier, people were resistant to doing genetic testing around this because they thought that, well, what's the point in knowing there's nothing we can do? Well, there is so much we can do. There really is. That we need to look at the risk factors, because yes, so you might have if you've got one ApoE4 gene, you might have a 30% risk of getting it, but you've also got a 70% risk of not getting it. So let's focus on your not getting it, and putting all the factors in place that are really giving you the best chance going forwards. And I think that is critical. We have that information that we can get that information, and we have ways, we have lots of things that we can do to prevent Alzheimer's then as we get older. And I think as we go on, the research is really, there's so much exciting research coming out as to what we can do and how we can prevent this disease. So I feel very enthusiastic, and I'm a big supporter of doing the ApoE4 gene and then working with it. I think I have to always say, if you're the kind of person that if you get a result like that, you are actually, you will feel your life is over and you cannot live another day. Obviously, I do caution. There are people that I've said, okay, let's not do it. Let's just focus on potential. You might have it, and let's see what, all the things we can do. Because certainly if it's going to affect you so badly mentally, then I wouldn't suggest you rush out and do it. It's also if you had to go to PathCare, you can't just arrive at PathCare and have it done. It's got to be through a doctor, and don't just do it through someone who doesn't understand what to do with that result, because that also is going to be not helpful for you and not beneficial for you, and you can't use that information as effectively as we can if we know what to do with the information. So
I'm going to squeeze in one last question. It says, is the APOE test specific to Alzheimer's or any form of dementia?
It's specific to Alzheimer's.
Okay, great. Thank you. I think, well, just a huge thank you. We really appreciate you taking the time to be with us today. And to everybody who's with us today, thank you for taking the time. We so love supporting you, and we so love being on this journey with you at DementiaSA. For those who aren't on our virtual support group or aren't in our WhatsApp communications, if you'd like to be, please feel free to put your name and number in the chat function, and I'll add you. I promise you there won't be any spam. It'll just be details of virtual support groups and webinars. But yeah, thank you so much, Dr. Ettelin. We really, we greatly appreciate it.
It's my pleasure. Thank you so much for having me.
And for anyone who wants Dr. Ettelin's contact details, where her practice is, you can message me privately, and I'll put those up. Or unless you want to put them in the chat function, if people wanted to, either way, people can reach out or contact.
If you Google me, you'll find me. Yeah. As long as you get my spelling of my surname right. Yeah.
I know. I'm so sorry, everybody. That was me who got this wrong. And I am sorry about that, Karen Court. That my humble apologies. Everyone who's ever had a WhatsApp or a message from me on this group knows that I'm not. My kindness is key. My spelling, not so much. I will add you, Yolanda. Thank you so much. And anybody else, if you wish to add. And yeah, everyone's just.
I'll quickly type my information there.
Okay, perfect. Okay. Thank you so much, everybody.